Again, we will start with anatomy and some physiology of esophagus, and then we will talk about the esophageal disease, motility disorders, and esophageal tumor, and some miscellaneous disease like foreign body, perforation, and strictures of the esophagus. We'll talk in brief about these diseases. Some of these diseases, they are overlapping between the general surgeon, and some of these diseases related also to the reflux, for example, internal medicine and gastroenterologists. But we have to shed the light because it is something called gray area between ENT and other subspecialty. But you have to know your limits, and you have to know when I have to transfer the patient to the other one or other subspecialty to take over. And first of all, that's the esophagus that we have to know. That's a fibromuscular tube. It's about 25 centimeter long in adult. It's extending from the lower end of the pharynx of the C6 to the cardiac end of the stomach, T11. We have to know that we have 3 normal constrictions. And these constrictions very important. This is the pharynx. This is the first constriction, which is called pharyngoesophageal junction. And then we have the second constrictions, which is at the level of T4, and we have the third constriction at the T10. So why it's important to know these constrictions? Because when I do something is called esophagoscope, which is a diagnostic and therapeutic instrument that we usually use it in esophageal disease, we have to know at this special distance of the esophagus, there is a normal constriction. There is like a narrowing mucosa on the mucosa. So this is not a tumor, this is not a stricture. If you see the mucosa is smooth, there is no irregular mass, there is no ulceration, there is no, for example, candida infection or any white patch. So that's mean this is a normal constrictions. So this is called esophagoscope. The esophagoscope, it is a lumen formed by the steel or stainless steel material. It's enumerated from 0 to 40 or to 45. It has a handling area, and it has a light source area, and it has a port area to put any instrument you want. For example, suction, if there is discharge, you take a crocodile forceps, punch biopsy forceps, and so on. So if you find, for example, a mass, you want to take biopsy, you will use a punch biopsy forceps. If you find, for example, foreign body, you can take it with the crocodile forceps. If you have secretion, you can do suction, for example. Again, so when we go from the oral cavity, the landmark of us, it is the upper incisors. So our eyes, when we go inside the oral cavity, it's on this enumeration, 1, 2, 3, 4, 5, 6, until 40. So we have to know when we are around 15 centimeters from the upper incisors, we will face a narrowing. So we have to be slowly, gentle, don't perforate the esophagus. You have to check the mucosa, because now the mucosa is folding on each other, mucosa and mucosa. You have to open it slowly. You check, is this area normal? No ulceration, no tumor, no stricture, no stenosis, nothing. And then you have to go to the other constrictions until you end by the cardia. So the pharyngoesophageal junction is usually at the C6, 15 centimeters from the upper incisors. And this is responsible by the coricopharyngeus muscle. The second one, the second constriction at the T4, 25 centimeters from the upper incisor, related to the aortic arch and the left main bronchus. The third one, it's 40 centimeters from the upper incisors, and it's usually T10, and it's related to piercing of diaphragm by the esophagoscope, so the related to diaphragm narrowing area. And then the esophagus, it's turn 15 degree and enter the stomach. It's not only 90 degrees it goes to the stomach or straight. It just go in 15 angle to 25 degree angulation. And this help also in prevent of regurgitation. So when I see this photo in next days, you know this is esophagoscope. This is not bronchoscope. This is not a sinuscope. This is esophagoscope. Enumeration, no port of ventilation like bronchoscope, only light source and handling area. The muscles or the layers of the esophagus consist of 4 layers: the mucosa, which is stratified squamous epithelium, followed by submucosa, and muscularis layer, which is inner circular and outer longitudinal. And muscles, usually it is striated in the upper 1/3, it is mixed in the middle third, and it is smooth in the lower 1/3. And at the end, we have adventitia or the fibrosa that's covering all these layers. The nerve supply of the esophagus, usually sympathetic and parasympathetic, and lymphatic drainage, it's come according to the thirds. Is it cervical or the upper third, thoracic or abdominal? A cervical usually to the deep cervical, thoracic to the posterior mediastinum, and abdominal to the gastric node. And the other things that we have to know, the swallowing phases or the physiology of the swallowing. We have 3 phases: oral phase or buccal phase, pharyngeal phase, and the esophageal phase. The oral phase, usually it is only the voluntary phase. The other 2 is involuntary. So the oral phase starts just when we initiate the food and the bolus at the oral cavity. Food mixed with the saliva converts into the bolus and then propelled into the pharynx by elevation of the tongue against the soft palate. So this is the first phase of the swallowing. It's called the buccal phase or oral phase. So just elevation of the tongue and make the bolus ready opposite to the soft palate. But you will see that you can talk and you can breathe. So the larynx is open while the upper esophageal sphincter is closed. Okay, so when we go to the other, so we want this bolus in the green, this is the food bolus. I want this bolus to go down through the posterior aspect of the tongue to the oropharynx and passing to the esophagus. So this is called the pharyngeal phase. So in the pharyngeal phase, we have 4 things to happen. Number 1, we have closure of the nasopharynx, closure of the oral cavity and oropharynx by the posterior aspect of the tongue and the anterior and posterior pillar, and contraction of the pharyngeal muscles. And we have also closure of the larynx and the epiglottis and opening of the upper esophageal sphincter. So 5 things happen to make the bolus go from the posterior aspect of the tongue to the oropharynx. So from the oral phase to the pharyngeal phase. So 4 closure or contraction nasopharynx closure, closure of oropharyngeal isthmus, closure of the larynx, and contraction of the pharyngeal muscle, relaxation of the coricopharyngeus muscle. So once it go down to the coricopharyngeus and passing the coricopharyngeus muscle, it's immediately re-close of the upper esophageal sphincter, reopen of the larynx, and the bolus, it will go down by peristalsis and the movement of the esophageal muscle, which is the inner circular, outer longitudinal, the upper, which is striated, as we mentioned, middle, mixed, and lower smooth type or smooth fiber. The esophageal regurgitation can be prevented by many things, which is anatomical related, normal anatomy, I mean. So we have the tone of the gastroesophageal sphincter. So if you have hypotonia, for example, it will cause a reflux. But if the sphincter down, it's maintained its tone, it will prevent the regurgitation. The negative cancellation and positive cancellation system or effect between negative and positive pressure between intrathoracic and intra-abdominal. The pinch effect of diaphragm at the lower third, the mucosal fold in the constrictions and the lower third, the esophagogastric angle, because the angle when the esophagus, as we mentioned before, it not go straight, it will go with a 15 or 25 degree insert to the cardia or the stomach. So all of these 6 factors, it will help to prevent the regurgitation and feeding of the food or the food go back to the esophagus. So disorder of esophagus will start with perforation of the esophagus. It can be 2 main etiologies: in instrumental trauma or spontaneous rupture. In instrumental trauma, usually during esophagoscope, if an not trained doctor, or if there is a foreign body, just you pull it out fastly, sometime you will do a perforation, especially if the foreign body it was sharp. Dilatation, during dilatation of the stricture, sometimes if we use bougie for strictures to dilate it, sometimes it will cause also esophageal perforation. Common site of the rupture usually بيكون في الupper sphincters in the instrumental trauma. السبونتينيوس rupture usually بيكون في البوست or بيكون في البوست emetic ruptures like some disease called Borheim syndrome, and usually involve the lower third of esophagus, but usually I think in the Borheim, yes, it is in the post diaphragmatic. So post one, this one. So the lower one third we have pre-diaphragmatic and we have post diaphragmatic. In the Borheim, it will cause a perforation in the post diaphragmatic area. So we have a perforation of esophagus after instrumentation. So the feature of cervical esophagus rupture are pain, fever, difficult swallowing, local tenderness, surgical emphysema in the neck. Sometimes you can feel it. For the thoracic esophageal rupture, it's usually more worse. The patient has high grade fever, intercapsular region, pain and referred pain, sign of shock, and you can say something is called, you can see something is called the Hammond signs because the air in the mediastinum. And we have to do X-ray if you have suspicious for these cases to check the subcutaneous emphysema and radiolucency in the chest and the neck. It may reveal a widening of the mediastinum sometimes, so it can see surgical emphysema, as we mentioned before, pneumothorax sometimes, pleural effusion or gas under diaphragm, if it in the lower one third. Treatment immediate, if we have a perforation and we have suspicious of perforation, we have to keep the patient MBO, start IV fluid, IV antibiotic. For ruptured thoracic esophagus, it's usually more serious and more conservative treatment compared to the cervical rupture. If the diagnosis is made early, within 6 hours, we can do surgical anastomosis and just close it. If it delay, we have no surgery rule. You just you have to drain the infected area only and bus and keep the patient IV fluid until we do, for example, anastomosis later on, re-anastomosis. Burns or corrosive injury to the esophagus, it can be due to the acid, alkali, or chemical swallow. It can be seen usually in children, neglected children in the home. They are reachable to the burns like Clorox or some very aggressive materials that we use it in pipe, for example. Sometimes we can also see these cases in emergency for suicidal attempts in adults. The things that we have to know that the burns in the esophagus, we have 3 stages: the acute necrosis, followed by granulation formation and sloughing of stage. And later on, we have something called stricture because the formation of the scar. So this is how we diagnose and how we put the patient on the scoring system if we have a burn. So we have 0 to 4, 0 is normal, and then 1, 2, 3, 4, and each of these scoring systems has its own strategy plan. For the mucosal layers, you have to do scope, like these pictures. You have to see which stage 1, stage 2, like this, okay? Stage 3, stage 4, what is happening? Okay, so this is coming by esophagoscope, diagnostic and therapeutic. Number 2, you have to do the pneumotic, or you have to do the motility test and sphincter test. And this is very important to use the manometry, guys, to check the motility. Is it normal or abnormal? And we have to check the sphincter. So we have to do manometry also to check these things. So according to this, is it present or absent? I have to put the patient in the scoring system, and later on, I have to give the patient the complication that will happen from each score later on in life. For example, the scarring formation and malignant transformation, and what is the follow-up plan and what is the treatment plan for these cases. We don't want to go in details about the treatment, but this is the things that you have to know only. We have different scoring system, and we have the 3 stages for esophageal burn. The benign structure of esophagus, we have burn, etiology, it can cause by burn, trauma, ulceration due to reflux esophagitis, ulceration due to diphtheria or typhoid. Sometime at the site of surgical anastomosis, it causes stricture as well. Congenital, and usually in congenital, it becomes in the lower third, not in the upper third. How the patient presents, usually dysphagia, first to solid-like tumor and then to liquid. Barium swallow usually establishes diagnosis. You can see a narrowing area in barium swallow. So if we have any abnormality in the barium, like filling defect, I have to do the next esophagoscope to exclude malignancy. Is it stricture? Is it malignancy? Is it foreign body? What is it exactly? And when I do esophagoscope, I will see, is it only mucosa, hard mucosa, or it is fungated mass. So I will take biopsy, whatever it is, fungated mass or it is stricture, to send for histopathology to exclude malignancy. And then if it's stricture, I will do treatment, which is a dilatation with the bougie, or sometimes it's very long section and very aggressive, I will do surgical excision with re-anastomosis. The other disease is very important, also Blammer-Vincent syndrome or Cobb-Peterson-Kelly. It's presented with, usually present with the woman actually, or female in the 40 years of life with dysphagia, iron deficiency, anemia, glossitis, angular stomatitis, chironekia, and chlorhydria. And the patient, it come with, so if I have a dysphagia, I have to do a barium swallow. When I do a barium swallow, you will see the whip in the postcricoid region. This before the bougie and this after the treatment. So this is the barium swallow, and you will see there is a filling defect here. So if I see a filling defect, that means there is something filling the esophagus from inside, because the contrast doesn't take this area. So I have to do esophagoscope. When I do the esophagoscope for diagnostic and therapeutic, I will see like this. It is not fungated mass, it is only constricted area. I have to see it is normal, it's not to the, it's not a constriction area. This is abnormal because it's like something, a web or something, it's not normal. So I have to take a biopsy, or I have to take biopsy, yes, to rule out malignancy, because we have 10% cases of this syndrome turn to postcricoid carcinoma, and I have to follow the patient every year. If dysphagia increase or not, I have to do barium swallow if dysphagia again happen. Treatment, you have to do dilatation with bougie in asymptomatic patient. In asymptomatic patient, just you find it accidentally, for example, when you examine other things, you just correct the anemia, vitamin B12, B6 deficiency. The motility disorder of esophagus, we have two main category, hypermotility and hypomotility disorders. The hypermotility disorders usually coricopharyngeal spasm, diffuse esophageal spasm, and nutcracker esophagus. And the most important thing is diffuse esophageal spasm. The hypomotility disorders, the cardiac achalasia, the most important one we want to shed the light. And we have a GERD, which is a gastroesophageal reflux scleroderma, and ALS, or it's called amyotrophic lateral sclerosis. So the hypermotility disorders like diffuse esophageal spasm, we have to know something. So the patient, he's come with dysphagia. But what's the pathophysiology? This one is related to strong non-peristaltic contraction of the body of the esophagus, while the sphincter relaxation is normal. So when I have this patient, dysphagia, I want to diagnose the patient, I have to do manometry to check the peristalsis of the muscle, and I have to do also the barium swallow. So at the end, I know this is a hypermotility disease, because I know there is a strong non-peristaltic contraction, but the relaxation of the sphincter is normal. So I will put the category that this patient, it is hypermotility, but this may be diffuse esophageal spasm, because the barium swallow goes with sign is called crocker straw or rosary sign. And the symptoms, the patient comes with dysphagia, odynophagia, substernal chest pain, simulated angina. And the complication, if left untreated, it can cause a diverticuli. Treatment usually with nitrate, calcium channel blocker, and even Botox injection. Surgical dilatation, sometimes we do it for lower esophagus in severe cases. The nutcracker esophagus is other type. It's almost the different things between it and severe diffuse esophageal spasm. It is peristaltic. While the previous one, it is non-peristaltic. The treatment option is the same. Cardiac chalasia, it is a hypomotility disorders and usually related to absence of peristalsis in the body of the esophagus. Okay, but there is a high resting pressure in the lower esophageal sphincter by the manometry. Symptoms again, dysphagia, usually to liquid, not to solid. So first to liquid and then solid, and usually the patient can feel the food come out through the mouth, and you just feel the things that he eat it in the early morning during the night, like the diverticuli disease. Diagnosis made by barium swallow. You can see the barium swallow, the bird beak appearance, manometry, it confirms it's hypomotility disease. Sometimes we have to do also for sure the endoscope to check is there any malignant factor in this case or not, because sometimes you can see the bird beak, but sometimes it is a malignancy over or double lesion. So we have to do scope to rule out any abnormality in mucosa, fungated mucosa, for example. So we take biopsy as well. So cardiac chalasia treatment, again, dilatation, lower esophagus, Botox, nitroglycerin. Surgical treatment, also it can be by something is called Heller myotomy or modified Heller's operations. Other disease esophagus like foreign body, usually the most common place for arresting of the foreign body, it is the first normal constrictor, which is the coricopharyngeus at the C6, as we mentioned before. So usually when you just to open the laryngoscope or use a laryngoscope, you just elevate the larynx and elevate the epiglottis, you will see the foreign body and just take it out. And usually in the foreign body, guys don't rely only on the anterior anteroposterior X-ray. You have to do lateral X-ray to check is it in the esophagus or in the trachea. These are other things that the fishbone that's present in the level of the coricopharyngeus. So sometimes you can see it, sometimes you couldn't see it. It depends on the calcium deposition in the fishbone. And we have to remove it by using a esophagus. Neoplasm of esophagus, we have benign and malignant. The most common benign is leiomyoma, followed by others like polyps, lipoma, fibroma, hemangioma. Treatment of benign usually by surgical excision. And the malignant carcinoma is usually we have a risk factor, smoking, alcohol consumption is a high risk for etiology. The most common cause squamous cell carcinoma, followed by adenocarcinoma. Usually the patient presents with the solid dysphagia, and he has a weight loss, referred pain to the back. Sometimes it causes aspiration if there is a laryngeal symptoms, very big tumor that's go to the larynx and penetrating the larynx. It will cause recurrent laryngeal nerve paralysis, for example, and causing aspiration, cough, hoarseness, and dyspnea. Spread of the cancer may cause also laryngeal paralysis or fistula formation. Diagnosis, if we have a patient with dysphagia, guys, so I have to do barium swallow. In the barium swallow, they will give us a lot of things. If there is a filling defect, so this one is not come. And yes, if I have like this, a barium swallow, and I have a filling defect like this, irregular, so that's mean most likely this is something. And most likely, if it's like that, it is a tumor. So I have to go next step to do scope, diagnostic and therapeutic. So I have to take a biopsy by the bunch biopsy and send for histopathology. After that, immediate, I have to do CT scan, CT chest, abdomen, and pelvis to stage the patient. And I have to do sometime MRI if it going to the aorta or, for example, to the heart sometime. And after that, I have to do bronchoscope as well. Why? Because sometimes the esophageal tumor is penetrating the surrounding structures like trachea, like, for example, larynx, and so on. So I have to do esophagoscope and bronchoscope. And after that, I have to put the patient on the staging system according to the TNM staging system. We have this TNM staging system. You don't need to know it in details, but you have to know that we have different TNM staging system depends on the histopathology. So each histopathology, يعني adenocarcinoma, it has a TNM staging. Squamous cell carcinoma, it has different TNM staging, but this is the general TNM staging for the esophageal tumor. So after that, I will just put the T1, M0, M0, M1, and then I have to say, is it early stage, late stage? And after that, I will decide what's the treatment. So the treatment usually for the upper 2/3 radiation is a treatment of choice for the esophagus. For the lower 1/3 is a surgery. And usually if it's the early stage, stage 1 and 2, we single modality. If it late stage, that means there is a MIDS or multiple lymph node levels, so I have to do surgery plus chemoradiotherapy. So this is the end of my session today. I think I just summarize it for you. And the things that we just discussed that you need to know it. And I know Dingra sometimes it's a little bit beyond our course, but this is the most suitable course, or the most suitable reference I found it, and we discussed it for many years that we don't have other option. That's, I mean, a reference that's house all the sections in one book. Thank you very much, guys, for your good listening, and I will check again the attendance, and if you have any questions, just feel free to ask me. شباب ما في questions عندكم؟ طيب مين اللي غايب عبد الرحمن؟ أرسلت لي اللي هي لأن 24 now 23. Okay, I need again عبد الرحمن check now. Otherwise, I will do it myself if you couldn't. I can call by names. Hello everybody. عبد الرحمن معنا؟
معك دكتور، بس ندور عبد الرحمن كان موجود.
شباب كيف كانت المحاضرات؟ في أي تعليق عندكم؟ في مشكلة؟ طبعا هذا السكشن هو very small section. Usually بيكون at the end of the main bulk, but I tried to make it today because I have only half day, and I don't like to start nose today, and tomorrow I will start again the remaining part of the nose, and then I will take esophagus, and then I will take the oral cavity. I think it'll become more difficult for you. So this is why I start with the small sections. Usually we present it at the end of the main sessions. If you have any comment, please let me know so I have to clarify it for you.
المعذرة دكتور، بس جتني مكالمة قبل شوية.
ما في مشكلة، حياك الله.
دكتور دوام بكرة بنكمل كم؟
حنبدأ تقريبا 8:30. حننتهي إن شاء الله قبل 4 بإذن الله. إذا خلصنا اليوم طبعا الحمد لله خلصنا السابقس، فحنخلص إن شاء الله قبل 4 بإذن الله. هو النوز ترى is very bulky and it's very heavy. That's mean في الاختبار بيكون الهيفي عليه بيكون أكثر من هذه الأشياء اللي نحن نعطيها السكشن الصغيرة. فالموست common في الإكزام I just say it at the first of my presentation بيكون الإير، بعد كده النوز، بعد كده الهيد اند نيك and larynx، بعد كده بيكون الفارynx، بعد كده remaining. You have to be smart when you study these things because it's very small. I mean very short period in a very huge condensed material. يا شباب فاهمين عليه ولا بكون سريع الكلام؟
ولا فاهم معك دكتور.
اوكي.
هلا عبد الله دكتور. دكتور ترى ارسلت لك التحضير في الواتساب.
تمام اوكي، يعني ما يحتاج
طيب.
نعيد التحضير. تمام. So I rely on it because yes okay I have it because the attendance is very important guys في المحاضرات. عادة إذا كان more than 50% في عندنا في جروب أتوقع A كان في حرمان 2 أو 1. ف just be careful about the attendance. فحتى طلع وراح لجميع يعني المسؤولين في الكلية، ما نقدر إنه هذا النظام مو فقط منا نحن supporting you، لكن هذا النظام من فوق يا شباب من الجامعة. ف
آه
that's it.
طب دكتور، بكرة بنبدأ 9 ولا 8:30؟
أم... انتوا ايش حابين؟ تبي تخلصوا بدري وتخلصوا متأخر؟
والله ودنا 9 عشان إنه على زحمات الرياض وكذا يا دكتور، إيش رأيك؟
طيب tomorrow وين حتكون؟ where the location؟
ارسل لي الدكتور عبد الله الزايد انه دوامنا في التحضيري على GR. ارسلها لك الرساله يا دكتور بس.
جربتوها قبل ولا ما جربتوها؟
والله ما جربنا القاعه، بس بالغالب انه ما فيها كمبيوتر. راح نشبك بالايباد. انا بالعاده اني احمل المحاضرات حقت الدكاتره قبل واشبكها في الايباد في التحضيري.
هي سيئة، أنا جربتها قبل في ال A1. القاعة جدا سيئة، ما حتقدر تشوف ايفن المونيتور تعبان جدا والبروجيكتور. فإذا قدرت إنك تشوف لنا قاعة ثانية في الكلية.
اللي اقدر في قاعه، بس يا دكتور انه على كلام الدكتور عبد الله الزايد المفروض ما نجي. لكنه اليوم حنا جينا كلنا الدكتور فهد وقال تعالوا مو مشكله للمركز الطبي، لان المركز الطبي حاليا ما في زحمه، لكنه الدكتور عبد الله ما يفضل انه يكون هناك يعني، بس هذا.
طيب بس شيك بكرة إذا كان فاضي في الصباح بدري مثلا، إذا قدرت تروح أو شيء.
ابشر ابشر.
بحيث إنه خلاص نخلص الكورس بس على الأقل ال ANT هناك، لأنه صراحة ما حتشوف أي شيء في البروجيكتور كأنك ما حضرت. يعني أنا أشوف الأونلاين أفضل من القاعات الموجودة هناك في الجامعة. يعني
ايه
أنا رايت بيفور مع عدة جروبات الوليد، وهذا البروجيكتور سيء جدا. ريزوليوشن ضعيف، كأنه تقريبا 45 بوصة. تلفزيون 45 بوصة، فصغير جدا وما حد حيشوف اللي بالخلف. الريزوليوشن تعبان جدا. فجست يعني try your best to get a benefit from يعني الاتندنس وكذا. otherwise يعني ما حيكون هذيك الفائدة. اوكي جايز،
تمام يا دكتور،
ولك
شكرا
دكتور.
لك.
التوفيق للجميع ان شاء الله.